Ready to get started. Truth's going to do a pretty good talk about EKGs. I just want to make a quick announcement. I know that several folks has kind of come up to me about some of the new trauma changes that we've seen happening in the trauma bay. Changes that we really didn't know about either, myself or Chris. So we went to the trauma department and was like, look, we need to sit down and talk about this. So we did. We had a meeting, Chris and I, and a couple of the trauma surgeons and Dr. Peel from the emergency department, some of the nursing staff, just talking about the interactions in the trauma bay, and if we're going to make some changes, we need to all be at the table discussing these changes and how best to incorporate not only the trauma surgeons, but our emergency medicine docs and nurses, and of course our EMS staff. So for now, they're kind of laying off on any changes they had sort of made. It really wasn't carried out in the best way, and not everybody was really on board with things. And they've assured us in the next few months we'll kind of all sit down at the table together and try to come up with kind of best practices that is, you know, national standards and such. So I just want to let y'all know, because I know I've had people come up to me offline, and several folks have come up to Chris asking about it. So we'll see where it goes, but hopefully we'll kind of come up with a better kind of policy on how all traumas will always be handled, any level 1, level 2 activations. I know currently it's kind of hodgepodge, depending if it's this attending or that attending and what have you, or if it's residents and there's no trauma attending. So that'll be coming, you know, it's in reality it'll probably be 6 months before it's actually all hashed out, and that'll be probably doing good. When you're trying to get everybody at the same table, it's difficult.
Well, they'll be changing out the residents in July. So
yeah, so that just adds to it. So bear with us. We know, I've always felt like the way traumas are sometimes handled has been a problem here, but there's some folks in that department that want to change that, and I think we can work with them to make it better. So I'll let him make you stand up here.
No, I'm good, brother.
All right.
I'm good. Tonight's going to be over 12 leads, interpretation, how we do things here at UC EMS. One thing I want to encourage before we ever start, if you have questions during it, please stop me. Let's talk about it and let's work through it, see if we can get through this. It's a lengthy presentation. I'm going to try to make it as fast as I can. It's hard to get a full 12 lead class in within 1 hour. So we're going to go over it as quickly as we can and try to make it beneficial for all of you. Quick objectives: we're going to discuss the general anatomy of the heart. We're going to identify and discuss the pathophysiology, the electrical conduction of the heart as well. Explain the relationships between the limb leads and the precordial leads. Explain and recognize proper electrode placement and 12-lead EKG monitoring. Predict the normal morphology seen in the 12 leads, and discuss and identify Rwave progression in the precordial leads as well. We're going to look at some of the reciprocal EKG changes that are seen in our MIs that we present out in the field, and identify some potential lethal arrhythmias as well. Electrograms, y'all know what this is. I mean, we see this every day when we're doing the putting the patient on the EKG. The information recorded on the EKG, of course, represents the heart electrical system, and most of the information on the EKG represents the electrical activity, the contraction of the myocardium. I mean, you can't have the artifact and the, the EMD, electromechanical dissociation that we used to see from interference within your radios or other equipment. In the early 1900s, Dr. William Einthoven, a scientist, discovered the electrical activity using a magnet, and he labeled what we know as today as the PQRST waves for us. And this was actually his early machine. I thought it was pretty interesting how he did it. It was a bath of salt where he had one foot and his arm in it trying to get this to work. So it's just, I thought it was pretty interesting and wanted to share it with y'all. It's a lot bigger than what we use today. The anatomy of the heart, I mean, you've got the blood flow. And if any of you want these slides later or something, we can print them out or email them to you guys. You know, the blood flow from the body goes to the right atrium, through the right ventricle, out to the lungs, and from the lungs to the left atrium, the left ventricle, and to the body. Just a quick refresher of blood flow in the heart. And no, I'm not going to go over all the bicuspid, tricuspid valves and all that. Electrical activity begins in the SA node, goes into the inner atrial conductions, to the AV junction, to the AV node, to the bundle His, the left and right bundle branches into the Purkinje fibers. Of course, here's just another breakdown showing you how it actually travels through the heart. And then we're going to start where it shows the electrical activity on our 12-leader EKG, the P wave. These are all in lead 2s, by the way, that we're looking at here. Is the pulse initiated in the sinus node. Then we have the beginning of the atrial contraction or excitation, as some people call it. And then we got the atrial excitation going. And then you have the complete cycle of the atrium being fired through the electrical system. You got the PR interval, which is the impulse delay at the AV junction. And then you have the QRS complex starting, where we begin the contraction of the ventricle. And then you have the ventricular repolarization as your T wave. This is something we don't deal with a lot. I mean, we don't carry calipers out in the field. We don't look at all this. I mean, we did probably in paramedic school one time. But your PR interval, your normal PR interval is 0.12 to 0.20 seconds. Your normal QRS interval is 0.08 to 0.12. And then your QT interval is 0.33 to 0.42. And again, here's the relationship of the entire electrocardiogram being mapped out with the electrical system going through the heart. Monitor leads versus 12 lead. A lot of you may ask, do any of y'all know where you actually get the 12 leads from? Because how many V leads are you actually hooking up on the patient? 6, thank you. And then we have how many limb leads? 6 plus 4 is 10, so where's the other 2 coming from? And that's what we're going to look at. The augmented leads is where it's actually coming from. So that's what we're going to look at. This is the just a representation of how we actually hook it up on the patient, what we're looking for. We're going to start with the 6 limb leads. And the limb leads view the heart on a vertical plane, also called a frontal plane. Everybody knows what vertical is? Is that up and down or crossways? Up and down. All right. Each lead has a specific view or angle of orientation. We use the 4 lead here at EMS. Of course, I still use the salt, pepper, ketchup method. But you got your right arm's your white lead, your left arm's your black lead, your left leg's your red lead, and your right leg is your green lead. We're going to start off with leads 1, 2, and 3. Quickly let you look at these, just the difference in the QRS complexes, how it changes when you're actually looking on your monitor. And then they're all 3 together. You can just see the differences in your P waves and your QRS complexes and your T waves as you're going through your rhythm strip. The Einthoven's triangle. I'm not going to spend a lot of time on this. Y'all want to spend a lot of time on your triangle? Okay, very good then. Now, one thing I do want to mention on your triangle. We use a 4-lead system. How many leads do you see in the triangle? 3. So my question is, does anybody know what the right leg lead does? Who said it? I heard it. Ground. It is a ground. That's the only purpose of that lead. It's just a ground to make the electrical pathway better, get a better picture. Because we used to not use 4 leads, we only use 3 leads. The augmented leads are your AVR, AVF, and AVL. It just gives a different angle, and this is where your 6 leads come in. You got 1, 2, and 3, and then AVR, AVF, and AVL. Plus your 6 precordial leads making up your 12-lead EKG. They're called augmented leads because the EKG actually amplifies the tracing. There's actually a mathematical equation. And if you're interested, I can give you those papers. It talks more about AVR, AVL, and AVF, how they do it. Basically, it takes lead 1 and lead 2 and divide it by this number, and it amplifies it, and that's how you're getting these different recordings on your EKG on your 12 lead. And it just shows you the different angles that it's actually looking at as well. It actually comes from the center of the heart and goes out. And then, of course, I got more EKG pictures, just showing you the difference. Remember this, AVR is always upside down to your lead 2. It's just a reverse, if you look at it. So just keep that in mind when you're doing your 12 leads. Yes, Randy, I know the P wave and the T wave don't look yet. They're a little, opposite, but it is upside down. And then there's all 3 augmented leads together on the same patient. And then there's your completed limb leads, what they would look like without your precordial leads. So P waves and QRS waves deflect mostly what? Speak up. Positive. That's correct. Which lead is always upside down? Randy? I just picked on you for this. AVR. AVR. And then, of course, where do you place the limb leads on the patient? Thank you, Bob. We appreciate you leaving your phone on tonight. Okay, this is one thing I want to talk to you guys about. We always know where to put the upper limb leads. Piece of cake. But we don't know where to put the leg leads. They have to be on the legs to get an accurate, true picture if you're doing a 12 lead. Okay? So just remember, putting them here when you're doing a 12 lead is not going to give you an accurate picture. Now, where do we put them on the legs? It does not matter, is what they said. But it has to be on a fatty tissue type area, soft fatty tissue area. It cannot be over a bony prominence. So if you want to put them on the thighs, that's fine, inner or outer. None of them that I read says it doesn't matter where you want to put them. Or if you want to put them on the ankles, which is easier for us because most of our patients have jeans on. But if you're doing a 12 lead, you're not going to get an accurate 12 lead if you do not put it on the lower extremities. Does everybody understand that? And I'm guilty of it because I get lazy and don't want to go down there by their nasty feet. I like it on the bellies. So what views can our limb leads see? I'm going to skip ahead because I took one with a picture. I thought it was easier to see with a picture. So you've got the cameras looking in, the old Kodak 35mm camera there, where it shows you where your AVL is looking into, your AVR, your 1, 2, AVF, and lead 3. The actual pictures that they're taking. Remember, it's a frontal plane, it's vertical. So it's looking up and down through the heart. So now we want to look at your 6 precordial leads. And these are horizontal, so it's looking through the heart, sideways. And it records the electrical leads activity from the anterior to posterior lead on our EKG when we're looking through the heart. Guys, I can't stress how important it is to do proper lead placement on 12 lead. You've got to do it. And I'm going to show you something. I actually saw a 12 lead the other day in EMS Station 4. And I looked at it after I went through this study, and they diagnosed the guy as having an MI. When I looked at the Rwave progression, I knew immediately the leads were not placed right. Could see it. And that's something y'all need to be looking at when you run your 12 leads. So truly that guy probably was not having an MI, which is poor lead placement. And that's why it's so important for us in the field to do the proper lead placement. And I'm just as guilty as probably all of you are in this field. We get in a hurry, we want to do it, we slap them on, boom, we're done. But I'm going to show y'all ways to look to make sure you're actually putting your stuff in the right lead placement when you're doing that. So here it is. V1 is the right fourth intercostal space, and V2 is the left fourth intercostal space. And I got pictures that I'll show you this a little bit better, make it easier for us. V3 is halfway between V4 or V2 and V4. And V4 is the left fifth intercostal space, mid-clavicular line. And V5 is horizontal to the V4 anterior axillary line, and then V6 is horizontal to V5 mid-axillary line. And I got your little placement thing there to show you. how to do it. And this is one where it just puts everything together, shows you exactly how the leads are actually looking into the heart, where it's looking at into the heart. And you can see V1 and V2 are in the septal wall, V3, V4 anterior, and V5, V6 are your lateral wall of the heart. And then you've got your 6 limb leads where they're looking at through the heart as well. And then I got these just showing you where the difference is. You got V1 is the septal lead. V2 is also your septal lead. V1 and V2 together, so you can see your septal MI if you have one. V3 and V4 are both your anterior leads. Showing you a little difference there. And then V5 and V6 are your lateral leads. You got those together. This is a completion of the precordial leads, when they're all together, the same patient. Y'all should be used to this when you do run your 12 leads. And this is the one I was talking about earlier to you guys, about the R-wave progression. R-wave progression means that the V leads, you should see the R-wave actually progressing. They get higher, they get more positive when you're running from V1 through V6. As you can see, the QRS complexes are progressively getting bigger. And that was the problem with that 12 lead I saw the other day at station 4. I had V1 and V2 bigger than everything else. So that let me know my leads weren't placed right. And I'm going to show you some more examples of that. So if we're looking at this, and this doesn't take into effect the limb leads, you got your V1 QRS, V2, V3, and V4. See how they're getting bigger? Your QRS complexes just keep getting taller, get a more positive upstroke. That's proper placement of 12-lead EKG. If you don't see that, then something's not right. This is one from Covenant Medical Center, just showing you on a real patient how they're getting bigger. I didn't mean to point at that lead too, sorry. Again, another patient showing your V1, V2, V3, 4, 5, and 6. So what's wrong with this EKG?
Poor R-wave progression.
Poor R-wave progression. Way to pay attention, Randy. Thank you, my friend. And this is what I saw at station 4. See how your V1 and V2 are bigger than your V3? You got poor R-wave progression. So that tells me right there that this possibly is not connected right. You got poor lead placement. And that's something we need to look at when we run our 12 leads. Something I didn't know until I started trying to prepare this class, so I thought it was pretty interesting. So make sure you're paying attention to that R-wave progression, how this is bigger than your V3. So you probably got V3 and V4 probably flip-flop where this is happening at. And then there's your answer, which is what we just talked about. This is the correct way. This is the bad way. So reviewing some leads. Limb leads look at the heart on the frontal plane. Precordial leads look at the heart on the horizontal plane. And it's important to place your V leads in the proper location and to also look for your R-wave progression. So here's your 12-lead EKG interpretation. In just a second, we'll give you a mnemonic that I use that I think is pretty helpful so you can always remember. But leads 2, 3, and AVF are your inferior for your MI. 1, AVL, V5, and V6 are your lateral. V1 and V2 are your septal. And then V3 and V4 are your anterior MIs. And this is the one I like to use. And it shows you where every one of them is actually happening. So your purple your lateral shows you where it's happening in your heart. And then your anterior shows you where it's happening, the injury is in your heart muscle. And then your inferior wall. Of course, they rotated your heart a little bit so you can see that. I use the mnemonic L-SAL, or is how I do this. And, or LISAL, excuse me, because you got to put the I in there. The way I do that is L stands for lateral, I stands for inferior, S is septal, A is anterior, and L is lateral. So if you're doing your LISAL, and you got your 12 lead, and it just goes the way it would, oops, you're going to come back, L for lateral. So I know that 1 and AVL right there together, you kind of have to memorize that part. Or is your lateral leads in a 12 lead. And then I for inferior, 2, 3, and AVL. We pretty much, everybody's got that one. That's an easy one to remember. And then I go to my SAL, or my S in the SAL. So you got your septal is B1, B2. And then your A is B3, B4 for your anterior, and then your B5 and B6 is your lateral again. So LISAL, L-I-S-A-L, is a little mnemonic I use when I'm looking at my 12 leads. And AVR we don't use. The hospitals do, the cardiologists like it, but we're just going to ignore it. So let's look at some discussion of EKG changes of an MI. And I printed this out. I thought it was pretty cool because now we're, when we're looking at myocardial infarction, realize the damage is occurring in the coronary arteries. And from there it goes down into the muscles of the heart because we're losing oxygen. And so what I did here is I printed you off or shared with you showing the aortic root. This is the aortic root, the big red thing. And then right here is where you actually have your coronaries coming off. So you've got your left coronary artery that branches out into your circumflex. And then you've got your RCA, right coronary artery, that branches out as well. And I'm going to show you some better pictures because not only does the LAD you have into the left main right here, and then it'll break off into your circumflex, the LAD, and you may have obtuse marginal as well, and a ramus at times. And I'll show you which one of those do. Not every patient has the exact same diagram or the pathways of the coronary arteries. And you won't ever know what you got until you go and do a heart catheterization. You could be right-sided dominant, meaning your RCA is bigger than your left side. So if you have the big inferior MI, you're going to have a lot of trouble. So that's actually, you don't want to see that because this right side is feeding more of your blood flow into the left side. But we'll go over that and show you more of that. So as I mentioned, myocardial infarction results from an occlusion of a coronary artery, lipid deposits that become plaque beneath the intimal lining of the artery can gradually narrow a coronary artery. Air embolies can also cause that, so you'll see that sometimes. That's very rare, but we have seen that happen.
I mentioned the big thing that happens is the plaque actually ruptures. You have a deposit of plaque, it ruptures, and then you get a clot. That's where you get the acute event.
Yep. So ST elevation can indicate an acute myocardial injury. ST depression and T-wave inversion can indicate myocardial ischemia. And then look for reciprocal changes on the opposite side of the heart in your 12-lead EKG. This is just showing you a little progression of the acute MI, showing you from top to bottom, your normal. And as it gets worse, you get your ischemia, then you go to your injury, then you go to your infarction. Just what the progression of your QRS complex will look like. Know what to look for. ST elevation is going to be greater than 1 millimeter, and know where to look. The biggest thing I see sometimes that people forget is you've got to look at your baseline. Of course, this is obvious that we've got elevation here. But you have to look at that baseline, and if you've ever worked with me, you'll see me take a piece of paper and actually draw a straight line through that EKG, even in the back of the truck, just to see if there actually is truly elevation going on there. Remember, don't ever just go off of what your monitor's showing. These monitors are notorious for showing ST elevation. Then when you print it off, you don't see anything. So don't just go off of what the monitor's showing. Make sure you print that lead off or do a full 12 lead on these patients if you're doing a quick 6 before you do the 12 lead. So look for in at least 2 leads. It can't just be 1 lead. So as you see here, he's having a massive inferior MI, lead 3, 2, and AVF. Here's ST depression and T-wave inversion, myocardial ischemia. So let me ask you a quick question. If this patient was presented to you with this rhythm and then was having all the classical signs and symptoms, would you run this patient in hot? Why you say no, Drew?
Rush it with nitro.
Treat it with nitro, I agree. But would you still say that they're having an acute MI?
No.
Yes.
How?
I would. They've already had the damage is already happening. I mean, you correct me if I'm wrong, Troutman.
Well, I wouldn't. I think the answer is kind of yes and no. At that point, with just ST depression, that means we have critical ischemia. We haven't actually had an acute infarction. You know, by definition, infarction now is no blood flow and tissue's dying.
Correct.
This is kind of right there. That hasn't quite happened yet, but it's probably going to happen pretty quickly. You know, and we'll see people at rest with big ST depression. But the other thing you'll see when you think of like angina and like somebody says, well, when I go out and garden, I get chest pain. I go sit down, it goes away. If we have that person get on a treadmill or go to their garden and work and then get an EKG, this is what we maybe see. Then when they slow down, then the depression goes away. And exactly what you said is also right, that you give the nitro, what's the nitro do? Vasodilates, you know, just a hair, but you know, we'll see some of the vessels later. They're not very big, but even just those few microns allows a few more red blood cells to go through, and you can actually just watch that depression go away often.
Now, is that reversible with intervention, like
Absolutely.
nitro? And
Yeah,
so that was, I think,
if you're seeing that right now, there's been no damage done. You're not going to see, so you don't actually, you know, ischemia just is what it is. It's decreased blood flow or decreased oxygenation to distal tissue. An infarct means there's no blood flow and that tissue is now dying. So when we think of ST elevation, an acute MI, acute infarct, that means the tissue is dying. And we try to get a stent in there as soon as we can, you know, the 90 minutes, because it's been shown if we reperfuse that area, we're probably not going to get it back to 100%, but we'll get a lot of it back. Same type idea in strokes and TPA, getting blood flow back. But these people technically haven't lost complete blood flow yet.
Would that be a code 3 transport to the hospital? Would you recommend that? Or?
Terry, is this the reciprocal change from the previous
No,
EKG?
it is not.
Okay, that's what I was
Right.
understanding.
Yeah.
Okay.
Well, that's why I wanted to put it out there. I want to see what y'all would do.
And I mean, that's a good question too, because really here I don't know nothing. All I have is 2 leads with depression. This may be reciprocal changes from the big tombstones, and he is acute MI. Code 3 with depression.
Depends on the patient.
Yeah, I mean, you know, he needs, yeah.
Well, that's why I asked, because I
You know, truthfully, the most important thing is going to be getting aspirin and nitro on board. When you get to the ER, we're probably not going to get super excited. It's not like they're going to wham bam and go straight to the cath lab. So I don't know that they have to be licensed sirens if you just have ST depression. Now, if you have any questions, is there a little elevation there? Then yeah, we need to get there quickly because we might be thinking about activating the cath lab.
And then here's your interpretation. So it's just showing you some reciprocal changes. This is a different one, EKG. These are just all different examples. So you got your 2, 3 and AVF, and then your reciprocal changes in leading 1 and AVL. So here's your inferior MI, and then you're looking at your lateral there.
Is that your drawing?
No, it is not. So let's look at some EKGs. Inferior MI, So you're looking at your lead 2, 3, and AVF. Everybody see the elevation? And then you do have some reciprocal changes there in lead 1 and AVL. Does everybody see that?
Yes.
Well, this is just pointing it out for you, the inferior MI. Now, we can do right-sided EKGs. Always consider a right ventricular infarct, or an MI, when dealing with an inferior STEMI. There's several different ways you can do it. I think this is the easiest way. And basically, you're just taking that V4 and moving it over to the right side in the exact same placement. Has anybody ever done one of these in the field? 1, 2 of you did? 3? I've never done one. So, if I see it, I don't worry about it. If it's inferior, it's inferior. I'm not going to waste time and do it again. Now, I'm not telling you you can't do it. So, what did y'all see when you did it differently? Any changes?
Elevation V4.
Everybody hear that? Elevation in V4. Here is an inferior and posterior MI. Showing you that. 2, 3 AVF. And you got your septal and some of your laterals, or anterior, leads in there. Just a different look. Ooh, wrong way. And Brian said V6. You can see that. Here's your anterior lateral MI. So you got V4, V5, V6, and V3. All of those. Got a little AVL there. And anterior septal MI. Lower septals V1 and V2. Then V4 and V5. And then this is the tombstone, or big one.
That's Brian's EKG.
And I've actually seen this. This is a good tombstone here. So, and that's what it means by a tombstone. It actually has that little curved shape in it. More of a global MI right here. Poor dude. He's infarcted everywhere.
Do you, on that prior EKG, do you know for a fact, was it an MI? Or this is just
This one
something-
here? Do I know?
No, the one forward. The, what you call global.
This one?
Yeah.
That I do not know.
Because like when I look at this, I mean, you're right, those look like tombstones, but when you have more or less ST elevation all over the place, exactly. So, yeah, when this first comes up, my real question is, I wonder if this is pericarditis, because you're irritating the whole heart, and you kind of get ST elevation all over. You know, who knows? We don't know what the patient end up having, but.
Yeah, no, I do not know about
Right.
this one.
But, you know, and that's whenever you do see ST elevation, just like we've been talking about the inferior versus anterior versus septal, does it make sense? You know, if you have ST elevation and lead 2 and V5 and that's it, well, that doesn't make any sense. You know, how does that happen? So you want to think, you mentioned the contiguous leads is very important. You know, you look at this, it's like, well, this is an inferior and a posterior and a lateral and a septal, probably more pericarditis. But it could be, you know, the right patient. You know, if this is a 20-year-old's EKG, probably pericarditis. If this was, you know, a 72-year-old that's had a cabbage and smokes, I'd still probably call it cath lab.
So I wanted to bring cath lab pictures to you, just so you can see a better view of what actually we're looking at and what the cardiologist is looking at. So when they're injecting, they actually go into the arterial system of the heart, and they do that through the legs. So they inject what's called a cordis, a sheath, and then they go in with the catheters that are already pre-made and pre-bent to fall into the coronaries appropriately. Occasionally you'll have some difficulty getting into them, but they're pre-made so that when you go through this aortic route and you come through here, I love the root, don't you? That's what it's called. Isn't it, right? And it actually is pre-made and pre-shaped to fall into the LAD or into the RCA. And then they inject the contrast and follow that through the II. This is called an II. This is where all your radiation comes from. And typically your cardiologist stands right here. You see he's got a shield to protect his parts down below. And then your scrub tech will sit here. Usually on the end down here you'll have a radiology tech that's running the dye when they do an EF and helps move the II here back and forth so they get the different pictures for the cardiologist. This is your left coronary artery. And this is the main. You can see that this is the catheter coming up through the aorta. Goes around that. I'm not going to say root. And it pre-bends into the left coronary artery, and it's engaged right here. It shoots the contrast through, and you can see the blockages right here in the left anterior descending artery into the LAD. Typically speaking, if you're in this, it depends on what degree you're at. I can't remember this now. I've been out of the cath lab for so long, but it's probably 30 degrees LAO is what he's in right now. But this longest vessel that you see is your LAD, and that's what it'll show. So this is your before picture showing the blockage, 100% blockage. And then if you had a clearer picture here, you would probably see that stent placement being put in there. And then I broke it out for you here just a little bit better, showing you the left main, the LAD, coming down. You have your circumflex. And they're calling this an intermediate. I call it a ramus. Not everybody has one of these. But pretty much the ramus is just, you're born with it. It sits right in between the LAD and the circumflex. And it's spelled R-A-M-U-S. And it's nothing wrong, just some people have it. It's just got better blood flow to the left side of the heart. And then here it is showing you the trifurcation, a true trifurcation of the left main. One of the things we have they've progressed a lot better with, anytime you saw a left main blockage in the older days, you were straight sent for open heart surgery. There's nothing they can do for it. Because what happens is when you go in there with a balloon or a stent and you try to put it in there, the time you go up with that balloon blocks all the blood flow distally to all of these vessels, is what it does. And so then you're going to go into refib, retag, and you're not going to come out of it, is what we would find in the cath lab. So it typically would not do that. Now with the new types of balloons and catheters and things that they have, when you go up with the balloon or the stent, it continues to allow blood perfusion to go through. And so just because you have a blockage in the left main does not mean you're automatically open heart surgery anymore. They can stent that and go through it. This is the right coronary artery. And this kind of shows you, the reason I like this one is it shows you where the conus branch comes off. These are electrical pathway branches, and this shows you it's going to the sinus node artery. So you're having that big inferior MI, you might actually see bradycardia, first degree, second degree, third degree AV blocks, whatever you may see. And the reason for that is because you're so close to that sinus node in the electrical pathway of the heart. So just remember that when you're looking at your MIs. The distal portion of the RCA, this whole vessel is the RCA. The distal portion of it is called the posterior descending artery, or the PDA as we call it. And this is your right-sided patient. This is what I was talking about to you earlier. This is the RCA right there. This is your left coronary and your LAD. And this patient is predominantly right. You can actually see where it started making collaterals and coming over here. These are collaterals that your heart starts building up to feed that LAD. Probably when they did this cath and they shot contrast into the left coronary here, you probably didn't see a whole lot of blood flow because it's probably completely blocked. Should be right there, going to about right in here would be your left main, but it's not there. So when they shot this, I guarantee you they probably didn't see any blood flow. His left main's completely blocked. Doesn't mean the guy had a heart attack or anything. He probably just was having some chest pain, ignored it. Well, the body will take care of itself. It starts making collaterals. So what happened is off the RCA, it started growing branches to feed this left system of the heart. Does that make sense? And so when he shot contrast into the right side here, you see the catheter, it started filling everything, backfilling it. And that's how this patient's still alive. Because he developed collaterals. Does that make sense to everybody? How that works? So what's happening in the MI? RCA infarct is inferior MI leads 2-3 to AVF. Circumflex infarct is a lateral looking at leads 1, AVL, V5, and through V6. LAD infarct is anterior septal, V1 and V2. Anterior is V3, V4, and anterior lateral is 1, AVL, V3 through V4. So if a cardiologist says, where's it happening, and he tells you inferior, and he says, what lead, what vessel is it? You tell him the RCA. Now you've got it. So what interventions are we looking at that we need to do for MIs? I mean, it's pretty much what we do every time we pick chest pains up anyways. You got your ABCs, your EKG, your 12 lead, IV fluids, 325 of aspirin, oxygen, nitro, morphine. One thing I don't think we do enough around here is we have a big inferior MIs. We do not have our defib or pacing pads ready. I don't think we do a good enough job with that. If they're having a huge inferior MI and you can see it, I'd highly recommend getting them pads on. It's not going to hurt. I mean, I would just have everything ready to go. If your chances of that patient getting sicker on you en route, going into VFib, or going into a block, a lethal rhythm, which you need a pace, are a very good chance of that. Early notification to the ER. Remember, transmit your 12 leads. And one thing that Donnie brought up that I forgot to put in here, and it still didn't get put in here, even though I did put it, I guess I forgot to hit the save button, is less than 15 minutes on scene, according to the new protocols. So don't forget that. Don't waste time on scene. All right, so case study, and then we're done. Any questions so far? Yes?
There's different ways of obtaining an accurate 12 lead. People place the patient sitting, semi-sitting, and laying down supine. What is the best place for the patient to obtain an accurate EKG?
Flat.
Flat. So the question, so everybody can hear it when doing that, Drew asked, what is the best patient position when acquiring a 12-lead EKG, and Troutman is saying supine.
Get less interference.
Less interference. Making sure you got the proper placement, patient supine, and then trying to make sure that the leads are not touching each other. I know that's hard. And then to make sure you're not rolling down the road.
Go back one slide.
Sure.
The other thing I want to mention, we talk about nitro all the time in these patients, but remember in inferior MI, you can get pretty easily induced hypotension with nitro. I mean, we've all seen nitro, the blood pressure comes down. So you don't necessarily withhold it, but just be ready for it. And, give IV fluids back if needed. But that happens, I mean,
I'm glad you
it's
brought
over
that up.
50% of the time.
Years ago when we first started dealing with the inferior wall MIs and stuff, when we started doing 12 leads, it was for a bunch of fluid to these patients. What is cardiology saying now about these patients? Are we still pouring fluid to them?
No, I think it's just if needed, if we do
Just to
get
maintain the pressure?
hypotension. Yeah. Yeah, I mean, almost everything they're getting away from pouring fluids other than sepsis.
Do you think they heard that? What Troutman was saying?
Yes.
Okay. You ready? So this is a case study I kind of made up. We'll go through it. You arrive on scene to find a 45-year-old male sitting on the couch with chest pain. Drew is his name. Patient is diaphoretic, pale, and clenching his chest. He states his pain is a 10 on scale, and then it woke him up suddenly in the middle of the night. Pain is constant and radiates to his back and up to his neck. Patient states he has no known drug allergies, no previous medical history, and he's not on any home medications. He presents with a blood pressure of 90/60, a heart rate of 78 that is regular upon palpation, a respiratory rate of 18 and O2 saturations at 98% on room air. Patient's wife states that he's already taken 324 milligrams of aspirin. And this is his 12 lead once you get him into the ambulance. So what kind of MI is this guy having? What's the first one that sticks out in your head? Inferior. And Donnie and I looked at this. This guy's probably having a little bit of maybe a global type. But you can see reciprocal changes in lead 1 and AVL. So we definitely know we're having an inferior. So I say the guy's having an inferior. Anybody want to disagree with that? Okay. So what kind of MI is the patient having? We already asked that. All right, so do we need an IV? Remember his blood pressure is 90/60. How many IVs do you want? 2. Okay. You want oxygen on the guy. Nasal cannula or non-rebreather? Okay. Some people want, does anybody want a nasal cannula?
I'll take a nasal cannula.
Okay. I don't think either one of them's wrong. I'm just curious to see which one you want to do.
What was his stats?
98% on room air.
Nasal cannula. He does not need a non-rebreather.
All right. Do we need to give him more aspirin? He's already had 324 milligrams by his wife.
You can eat that one extra.
You want to give him 1 more milligram?
Let him lick the aspirin.
Got the pill cutters in the ambulance, baby, ready to go.
Hold the package.
Yeah.
Dump the dust.
Okay, so what's one thing you do need to look at on that patient's aspirin before you decide that? Somebody said it. Expiration date, exactly.
And to make sure to if you don't give it, document why, because the patient already took.
Yeah, because Bruce then comes to me and says, Trina, come on, man, they didn't even give him aspirin. Come on. BTA. Nitroglycerin to this patient.
If you got a good line, oh yeah.
I agree with you, Brian. I don't withhold nitro just because they're inferior. And just like Troutman was saying, just be cautious with
His
it.
blood pressure was 90 systolic.
It was 90 systolic. But Brian's saying we've got his pressure back up after giving IV fluid.
All right.
So that's what he was saying.
Hold on
Okay.
then.
If you know for sure you have an MI or inferior, would you throw nitro at him before you got your lines?
Absolutely not. Absolutely not. You set yourself up for failure. And that was my next question. You can't get an IV. Would you give nitroglycerin? No.
You're really playing with fire.
You are playing with it.
Remember, probably 50% plus of these are going to decrease their blood pressure, by more than just a little bit.
Okay, so do we need early notification?
32 and 3.
32 and 3 UNC. Okay, what's some potential risk involved with this patient besides the bradycardia? Arrhythmias. Exactly.
Pressure issue tanking.
Pressure tanking. Good. I just want you to start thinking about that a little bit. And I have the MFE pads ready. Does anybody remember what the MFE stands for? Wow, they paid attention in our last class. So nice. Multifunctional. Any questions, guys? I know it was fast. It was kind of broad.
Guys, one comment. Who takes, on a category 10, who takes your monitor in?
Nobody.
Nobody. Probably. It's maybe something we want to think about is, if we're going on a Category 10, if we take our monitor in while they're going to get the cot, I can already have a diagnosis or have a good look at the heart, maybe from inside the house. Maybe from more, especially when we're doing serial 12 leads. Maybe something we think about. A lot of services across the United States make it mandatory that they take the monitoring in the lot on a lot of patients. And so something we may have to look at some point, but think about that in your mind. It may not hurt to take that monitor in. If you're going upstairs, if you're going to a second-story apartment, definitely. That way, because I know I'm going to be delayed getting to my truck. So we need to think about taking the proper equipment in when we go on a regular basis.
All right, test. Christian, called you out, not for everybody.